EM board bombs.
Welcome back to EM Board Bombs. What's up, Briggs?
Let's go.
Let's go. Today's going to be pretty intense. We're going to be throwing high-yield board knowledge because I think it's a special time of year. What is it, Briggs?
It's ITE time.
It is.
Let's go.
One of our Rapid Bobs subscribers was like, I tried to listen periodically, but I'll be honest, I am just crushing Rapid Bobs right now.
It's easy to get into a theme of just listening to 10 in a row. I've done it before too.
I
when
know,
I'm really listening to some of them, you're just like,
but
okay,
the funny
let's
thing
go.
is they followed it up by telling me I'm doing a lot of walks outside with my dog. My dog is getting great exercise. Anyways, it was funny. Yeah, so we are EM Board Bombs. We like to drop high yield board knowledge. Today's going to be a special episode. We'll get into that, but first, shout out to EM News, one of our sponsors, the only sponsor, the only one we allow. We say no to everyone else. So no thank you to everyone else. But EM News is amazing. Why are they amazing?
They're just great content. Great
they
people.
really are. It's amazing content.
The voice of emergency
EM
medicine.
News. They're the voice of emergency
Speaking
medicine.
to the man, that's what they do.
Yeah,
Speaking
it's
to the
like
man.
every EM provider out there can basically get a subscription for free. It's pretty awesome.
Yeah.
And they have very engaging articles, some written by you, Dr. Briggs.
Thank you. That's very kind of you.
Yeah,
When they run out of when they run out of ideas, they're like, well, I guess we could put him in there.
All right, let's get into it. So this is going to be Rapid Bomb Blitz. We're going to do part 5 and part 6. So we're going to get into 5 pearls each. And this is something that we do on our Rapid Bombs podcast. If you know about our Rapid Bombs podcast, like 3 to 5 minute long episodes, high yield board contents, our premium pod, you can find it at emboardbombs.com. Just click on the question bank. And what we do for these Rapid Bomb Blitzes is basically just crush through pearls. That's especially important right now with ITE coming up. So that's why we're going to focus on it. So this is going to be, yes, let's go. So we're going to do 5 pearls. We're going to do them pretty fast, like we do Rapid Bomb style. And then we're going to have a part 6 as well. You can see all our previous parts, obviously, on Rapid Bombs. Part 6 is going to be made only for our premium podcast subscribers. But again, we're going to, for everyone, just drop part 5 so you can get an idea of what we do and get some high yield board content down. All right, Briggs, start us off.
Sweet. Pearl number 1. Rashes associated with target lesions. This is a good one.
Oh, yeah.
All right, what's the most classic one? You have target lesion on the skin, no matter where you are in the world.
Yeah. I mean, everyone thinks of like erythema multiforme, right?
Yep.
Yeah. I mean, that's like the EM, as they sometimes call it. What are the 2 other ones?
And always are, at least for the test, I think, they're going to put that on a child, erythema multiforme.
Always. Yep.
That's what they're going to do. The other 2 is going to be Lyme disease, and then Stevens-Johnson syndrome, which is sort of on the spectrum with erythema multiforme. But
yeah, and we'll get into that as well.
Yep.
So these target lesions, they're described as literally looking like targets. This is like one of those few things
we
where
tell
like,
it like it is.
That looks like a target lesion.
Bullseye.
Yeah, bullseye. So kind of multiple concentric rings. You have the center, middle, and outer ring. Getting into this pearl some more, erythema multiforme, or EM, is most commonly associated with target lesions. It's
Absolutely.
a hypersensitivity reaction, and it's often associated with infections and medications. Get into SJS.
Yeah, Stevens-Johnson, we've done multiple podcasts on this. Main podcast, multiple Rapid Bombs. We've really beat this thing to death. So Stevens-Johnson syndrome initially presents with target lesions, erythema multiforme, and then it develops into mucosal involvement. Such a key thing here. That's the difference on the test. If they say, hey, look, here's a picture of blank, and you guess it's erythema multiforme, and they say, what is this, or what's the plan? If they say it's mucosally involved, or there's ulcers in the mouth or something, you're saying that's Stevens-Johnson, and that's an emergency. Versus if it's not, and they look great, it's, okay, go home and stop taking that medication.
Exactly. Yeah, fine.
It can also be associated with viruses, erythema multiforme.
Yeah. Just, it's poor form not to go through their med list, by the way, and send them over.
It is.
All right.
Yeah. Sulfa drugs, keep taking them. Anyway. Pearl number 2. Management of a sebaceous cyst. Doctor's saying I have to give you a compliment, which I do all the time around here. But this
That's
is a
nice to
special
hear.
compliment.
Sometimes I feel like I don't get enough of those from you, but that's fine. That's neither here nor
No,
there.
my long-standing friendship with you should be enough.
That
But
is. That
this
truly
compliment is me making a diagnosis of a sebaceous cyst the other day based off the Rapid Bombs podcast. So thank
Oh,
you.
heck yeah.
It was
That's
on my
awesome.
mind. I saw a patient with it. And I was like,
Mm.
this seems like a sebaceous cyst. And the way he described it looked like it too.
There
So
you go.
what is the details of this? Why don't you rehash it again for people that didn't enjoy hearing that on the Rapid Bombs?
Yeah, we're going to condense this down. So,
Yeah.
management of a sebaceous cyst, you're always going to be presented with the cyst that's on the back. Now, it can technically be in other places, but on the boards, it's always going to be on the back. It's not going to be acute. It's going to be present for months. They're not going to even say like 1 or 2 weeks. Almost certainly, they'll set it up as something that's been present for months. The key thing is these things can become inflamed or develop infection. They're not going to really want you to hash out, is it inflamed versus,
Right.
they're not going to make you do all that.
No.
It's really going to be, is it infected or not?
Right.
So if there's signs of infection, so overlying erythema, just exquisite tenderness, signs of fever, it's okay to IND and start the patient on antibiotics.
Right.
The key part, though, is they need a referral to dermatology in the outpatient setting because these things recur very frequently because in that IND, you didn't take out that whole, I hate that word, capsule.
Sac.
The capsule, right? You didn't take it all out. I know. It just sounds weird, honestly.
Sac.
Right? So if there are no signs of infection, this is the key. If there are no signs of infection, do not IND these folks.
Nope.
And the key thing that they're going to want you to do is refer that patient to dermatology in the outpatient setting. So that's the key.
Bingo.
Yep. And so I think they're going to want you to really understand that these things recur and that without definitive kind of management in the outpatient setting, you're not doing the right thing.
Right.
Hey, can you get into Pearl 3 here? So
is that because you don't want to pronounce it?
Exactly. That's exactly what I was thinking when I saw it. I was just like, ugh,
HSP, Enoxolin purpura. This is one for the ages from med school, still causing problems. Most common vasculitis in childhood.
So you need to know it.
Yep. So the demographics here, 2 to 11 years old, and it peaks around 4 to 6 years of age. They are always going to give you a child with this. Is there adult onset? Sure. Does it matter? Maybe for real life, but not on the test.
I know. Really
the symptoms are going to be classic. Some type of viral URI, as so many things are caused by.
I know.
And then you have belly pain, non-descriptive belly pain, and this rash. And the rash is so classic, and I know everyone knows this already. Palpable purpura on the back of the thighs, back of the legs. It sometimes can spread elsewhere, the lower legs as well. It's so classic looking.
Oh, yeah.
And in the course of pathologies, some IgA-mediated vasculitis. It's associated with this weird complication that you have to know for boards.
I know. They just love to ask
It's so classic, intussusception.
Right.
As well as, of course, kidney nephropathy.
Nephropathy, right?
I guarantee they're going to say, 5-year-old child comes in, they give you a picture of the rash, and they say, what's the next test you need to order? And they're having belly pain. And it's going to be what? An abdominal ultrasound to look for intussusception.
I know.
I just gave you a board question right there.
Right? Because you're going to look at that and you're like, oh, I know this. This is HSP. Yeah. I got this.
And then they're like, oh, what's the third question? Yeah, tertiary question.
And Briggs just told you that, right?
Yeah,
especially
exactly.
with the abdominal pain you're going to be rolling out.
And the treatment's not even that interesting. The treatment is just supportive care.
Yeah.
Sometimes steroids, but that's a whole different topic, just supportive care.
And that's why they like to ask those follow-up questions, right?
Yeah.
They assume
that's more
that
high
you
yield.
know what it is.
That's more high yield than the treatment, yeah.
Exactly.
Hey, let me ask you a question. Do you ever wake up in the morning and think about, what if you had painful, non-ulcerative red nodules on the shins? What is that?
This is Pearl 4 we're getting into.
I saw this the other day at work. A patient had it.
Oh, I love it. I love it. So painful, non-ulcerative red nodules on the skin. On the shins, rather.
What did I say?
I said skin.
Did I say shins or skin?
I think you said just shins. Shins, everyone.
Shins.
Let's clarify that.
Shins.
Painful,
The shins.
non-ulcerative red nodules on the shins.
I'm pretty sure I said shins.
Erythema nodosum. You said it right. I didn't, Briggs. So erythema nodosum. Most common in women. This is like, they're not going to present a male. Okay.
No.
You're talking about like a 6-to-1.
And they're going to be 30 years old.
To male ratio, right? I know. Around 30 to 50 years of age. It's usually self-limiting. The treatment here is going to be NSAIDs. The key thing is, what can this be associated with, Briggs?
Scary things. Sometimes drug exposure. So again, sulfa drugs make an appearance. Is why I don't ever prescribe Bactrim. And inflammatory bowel disease, Crohn's, ulcerative colitis, unfortunately.
Right. Yeah, those types of things. And then they might ask, for this patient they present, what is the most common infection that's the culprit or cause of it? And what's that going to be, Briggs?
Strep pharyngitis.
There you go. All
like
right.
pandas.
So I feel like we just packaged up like 3 different ways this question could be asked,
Yeah. And now we're going to end on a high note.
I know.
Rashes associated with vesicles or bullae.
Ooh,
Not good if you see bullae.
No.
Okay, so let's get the most obvious one out of the way. Pemphigus vulgaris, bullous pemphigoid. Okay, put those out the door. Yeah. We all know those. You're rarely going to see them.
Right.
What are the 2 scarier ones that you really don't want to miss? Of course, if associated with significant pain, we're thinking necrotizing fasciitis.
Yeah,
necrotizing,
like tachycardia, hypotension, fever,
or
necrotizing fasciitis, like all day, every day, right?
And then weirdly, let's say you walk into the room and you have a patient with arthralgias, and then they have some vesicles on random locations throughout their body, and they're a young male or female, maybe a college student, no offense for labeling, disseminated gonorrhea.
Boom. Like I just ended, we're ending it on that.
Yeah, that's it.
All right. So again, that was a preview.
Make good decisions.
Make good life decisions. I mean, I feel like that's something we say to like every patient as they leave.
Oh yeah.
You should be making, please make good life decisions.
Right.
So that's diabetes. Hey, we're going to have a couple of more of these coming out on our Rapid Bombs podcast. Again, it's going to be Rapid Bomb Blitz. Hey, Briggs, we're going to get into part 6 for our premium subscribers. Everyone else, best of luck on ITE. We're going to be dropping some more podcasts.
Everyone else, we love you, but good luck. Deuces.